Okay, so let's get started with infections. Um, this is one of those topics which is very high yield on your exams. And it's a very high yield topic because it's always going to be there. And sometimes, board questions can be quite infections heavy. It's an easy topic in the way that either you know it or you don't know it. So, my advice to you is that don't get daunted by it, because some of the slides tend to look busy, but they're very specific things that they're asking you in those slides. So there are two aspects of the infectious diseases. One is the slides that I'm going to cover today, which is pretty much the slides that they're going to ask you. The second is, some of esoteric stuff, which I do have a PowerPoint, which I just remembered I should have shared that with you prior to the start of the class, but that's okay. I'll have Anthony send that over to you after we are done. So just pay attention, and we will take it from there. The other thing is that the recording from yesterday, you guys did receive it. Everybody is good with that?
Yeah, it's
Yes.
Okay, good. Okay, so let's get started. So we'll start with the bacterial infections first, and a lot of this we have already covered in the bacterial infection, so it's kind of like a revision. So one of the most common bacterial infections we encounter is impetigo. As you all know, it presents with the subtle subcorneal blister with acantholysis and neutrophils. The neutrophils are more predominant than the subcorneal blister, and in real life, you do not really need to see the bacteria to make the diagnosis. In fact, in most of the instances, we do not see bacteria. But for your board purposes, they will illustrate to you slides where you do see bacteria. The closest differential diagnosis of it in the absence of bacteria when there is acantholysis is pemphigus foliaceus, as you guys know. So you can see here there is a nice subcorneal blister. It's predominantly neutrophilic. So the first job is to be absolutely sure that what you're seeing are bacteria, because the neutrophilic debris can sometimes mimic bacteria. So bacteria will be present as these fluffy clouds and colonies. They are the most commonly staph. Those strep can also occur, and this presents as these bunch of grapes and clusters in the stratum corneum. These are all gram positive cocci. So this is how a gram stain would look like. We are essentially looking for two colors, blue and pink. So the gram positive is going to be blue. So you can see that these bacterial colonies, they all stain like these clumps of blue bacteria. So that's gram positive cocci, which is bullous impetigo. The next bacterial infection is going to be pitted keratolysis and erythrasma. So both pitted keratolysis and erythrasma are produced by Corynebacterium, which is a filamentous gram-positive bacteria. So this particular organism, it incites minimal inflammatory response. So when you see it, so there can be two types of biopsies. One is a biopsy from the palmar or plantar surface, most commonly your plantar surface, so the thick acral skin, which is pitted keratolysis, and the second one will be from an intertriginous site, like an axilla or something, that is going to be for erythrasma. But overall, the biopsy looks minimal inflammatory. So this, like tinea versicolor, will not incite much inflammation at all. So it looks essentially normal. So the bacteria, when you look at it, it looks intermediate between the size of the bacteria and a fungus. So you really don't need a stain to see it. It will stain both with gram as well as with the PAS stain, but you can actually visualize it. So like tinea versicolor, you can see it. So these are beaded filamentous bacteria. So they're bigger than your conventional bacteria and smaller than fungus. So what you can see in here, these are all the clumps of bacteria, but you can see that many of them look like little beads and filamentous organisms, which makes you think about a fungus. But these are also clumped and they are much smaller than what a fungus would be. Does everybody see the filamentous bacteria?
Yes.
Okay, so that is erythrasma. As I said, these are gram positive and they are also going to be PAS positive. So they will stain with PAS as well. Let's see some more examples of erythrasma. So like that was pitted keratolysis. This is going to be erythrasma. So you can see this is an intertriginous site. The background of an intertriginous site always looks undulated papillomatosis. It almost produces like a psoriasiform pattern. it has incited some inflammatory response. This is largely because it's the intertriginous location. And I'll show you the bacteria in here. You always have to analyze the stratum corneum really carefully for erythrasma. So that's where the organism will lie. So you can see here these bluish, it looks like kind of little busy. And this is how the best visualization you will get. Like it will look really busy, but it is without a neutrophilic response. So it's not really bacteria. And, they are not like very well defined, like what you would see as a fungus. So they are smaller than the fungus. So that is again erythrasma. I'm going to show you some more examples so that, you guys can remember it. Let me just find the slide. So you can see this is again from the intertriginous side. It has incited like a psoriasiform response. It's a slightly thick conified layer. And you can see these beautiful. This is actually really nice. So you can see how there are clumps of bacteria and they are the filamented beaded stuff pouring down around it. This is like as perfect as it can get. And right now I'm on 60x. That's actually the advantage of using, this is one time when I really like digitalized slides, because maximum on the low power or maximum high power that you can go on a microscope is 40x. So this is 48x. You can even go higher, but the higher you go, the more bloody it gets. So the best is to like stick to anywhere between 40 to 50x to be able to recognize the organism. So that is erythrasma. Okay, so those two are the common conventional bacterial infections that you will get. Okay, so now let's come back to our other organism. Let's talk about syphilis. So let me just go back into it, refresh it. Okay, so the, syphilis. So, syphilis can present in varying flavors. The primary chancre of syphilis will look like indistinguishable, as you know, from any other ulcer. So you do have to have a high index of clinical suspicion whenever we see an ulcer in the genital area, especially with these features. The features are prominent vessels in the base of the ulcer. So you can see these prominent vessels. The vessels, the endothelial cells almost always look very activated. And the ulcer bed has a mixture of infiltrate, especially with plasma cells. So plasma cells, never fail you for syphilis. So if you're seeing plasma cells, you're kind of like obligated to do a Treponema pallidum immunostain. So you can see these nice plasma cells within the infiltrate. So that a very acute looking ulcer with activated prominent vessels, endothelial cells, and a combination with plasma cells is highly indicative of chancre of primary syphilis. Now, the Treponema pallidum, the next step in this particular case to do is a Treponema pallidum immunostain. So we do not do things like a Wart and Starry stain. That's extremely low yield. The next step would be to do a Treponema pallidum immunohistochemical stain. The Treponema pallidum immunohistochemical stain is going to highlight the spirochete organisms, which are best highlighted in the basal layer of the epidermis or around hair follicles. So basal layer is where you start first, and you can see this is a brown chromogen. In my lab, we have now shifted to a red chromogen, so they can also look like red organisms, which is easier because then you don't confuse it with dendrites of melanocytes. So here you can see these kind of spirochete, these filamentous organisms, which are spiral organisms, which is all your spirochetes for Treponema pallidum. Okay. So now primary syphilis is that. Now, when you come to secondary syphilis, basically anything is fair game. You can get a wide variety of, inflammatory reactions in secondary syphilis. So essentially, it is a great masquerader. It can look basically like anything. But what are the most common reaction patterns that are very, very suggestive of syphilis? So the number one reaction pattern is what is known as slender and dirty Riti ridges. So slender and dirty. So they are elongated Riti ridges. So when you look at this biopsy, they look like elongated, thin Riti ridges, but they are dirty. Why are they dirty? Because if you go up on high power, you can see all these neutrophils, which are kind to extravasate into the epidermis, and some of them get broken down. So these kind of dirty but elongated Riti ridges. And this not many diseases do that. In fact, not anything is coming to my mind that would do that, the elongated and the dirty reedy ridges, you can see how even the neutrophils are trying to pour out into the epidermis. And then when you look in the dermis, you will see plasma cells corresponding to it. So plasma, a combination of plasma cells and neutrophils should always make you think about syphilis. The neutrophils are not a very predominant, but they are there. They are subtle. So neutrophils and plasma cells should make you think about secondary syphilis. So this is one of the most common reaction patterns that we see with syphilis, this kind of variable degree of spongiosis, but these elongated dirty reedy ridges with neutrophilic exocytosis. Around the vessels, they are neutrophils, and most importantly, plasma cells. You can see that the lymphocytic infiltrate around the vessels, it could be variable. It could be superficial, it could be superficial mid-dermal, it could be superficial and deep dermal. Around the vessels, notice one thing, and your eyes may not catch that, which is okay, but I still want to tell you that the lymphocytes in syphilis always look really activated. So first of all, when you look at the aggregate around the lymphocytic infiltrate, it looks kind of tight, but at the same time, it has spaces in it. The spaces is because it is always going to have an histiocytic component with it. That's eventually going to form a tuberculoid granuloma. So it kind of looks like an expanded infiltrate, and the lymphocytes look large and activated. And you can see the plasma cells within the infiltrate. So picking up on that reaction pattern is very important. The more the slides of secondary syphilis you look at, honestly, like the first time when you look at the lymphocytic infiltrate, it always makes you think, oh my God, could this be lymphoproliferated? Because the lymphocytes look atypical. When you are thinking about that, you should really think about syphilis, that this is probably lymphocytic activation from that organism. It can produce you a lot of lymphocytic atypia. So this is eventually going to form you a tuberculoid granuloma. So you can see how the lymphocytic infiltrate around the vessel is kind of expanded because it's histiocytic and it has plasma cells. So this is one of the most common reaction pattern that we see with it. The next reaction pattern is going to be the pattern that we have already discussed, which is very, very pathognomic for syphilis, and that is tuberculoid granulomas. So now you can see that how the lymphocytic aggregate around the vessels is kind of expanded. So you can see these nodular aggregates around the vessels, which are oriented perpendicular to the epidermis. So that's your tuberculoid granulomatous pattern. So when you go up on high on that, so now you can see it's nicely forming you tuberculoid granuloma. You can even see some histiocytes and giant cells, and my arrows are pointing towards the plasma cells. So the tuberculoid granuloma, which has got plasma cells in it, should always make you think about secondary syphilis. And notice another thing that, there will be some degree of neutrophilic extravasation, but it's not predominantly neutrophilic. So it's not suppurative and granulomatous. There's some neutrophils coming out, but it's predominantly a lymphohistiocytic plasma cell infiltrate. So that is the pattern of secondary syphilis. Here, the epidermis does not show much involvement, but you may still notice that there are some elongated reedy ridges in this pattern, but it is predominantly a dermal pattern. So tuberculoid granulomas with a hint of neutrophils, but with plasma cells, again, makes you think about secondary syphilis. Okay, I'll show you the next reaction pattern is the reaction pattern which falls in the category of your lupus-like pattern. So superficial, deep, dense lymphocytic infiltrate. So when you look at this reaction pattern on low power, doesn't gyrate erythema or tumid lupus come to your mind because it's a tight lymphocytic infiltrate. So that is why a superficial, deep lymphocytic infiltrate pattern, one of the 7 L's that you deal with, like light, pleva, lichen striatus, tumid lupus, you also have syphilis or Lewis in it. So superficial, deep lymphocytic pattern. But when you go up higher on the lymphocytic infiltrate, you will see that it has predominant plasma cells. So tumid lupus and typical classic lupus does not do that. So a tight lymphocytic infiltrate pattern with plasma cells should also make you think about secondary syphilis. And you can see the nice plasma cells in the infiltrate. It was something I was going to mention, and it's kind of like I've forgotten. It'll come back to me. Okay, so these are the most common 3 patterns we deal with. So we have the dirty, slender, reedy-rich pattern with neutrophilic extravasation. We have the tuberculoid granulomas with plasma cell pattern, and we have a superficial, deep lymphocytic infiltrate with plasma cells. So plasma cells, remember, bottom line should make you think about syphilis. So those are the 3 most common ones that you will encounter. Okay. Do you guys have any questions on syphilis? It's definitely going to be there on your boards. And we do see almost one case of syphilis almost every month. So it definitely has made a comeback. Any questions on that? Okay.
How frequently are you doing the spirochete stains?
I'm sorry, say that again.
How frequently are you staining for treponema for syphilis, like the spirochete stain?
So honestly, my rule is, to me, if I cannot make sense of the reaction pattern, and if syphilis is always on my radar because it's a great masquerader. So if there is a discorrelate between the clinical and the histology, the clinical is not straightforward, and the histology is also very ambiguous. It has multiple reaction patterns. I will do a treponema pallidum stain. It's a very cheap stain to do, but it is very high yield. In almost every workup of a patient which comes in with like a cutaneous lymphoproliferative neoplasm, we will do that. Unexplained causes of alopecia, we will do that. So it is a stain which is pretty frequently used in a lab because it can be pretty gratifying. And we have found cases which are very like not straightforward histologically or clinically. That's always a hint that let's just make sure that this is not secondary syphilis.
Okay, thank you.
Yeah. The one more thing that keeps on forgetting in my mind. Yeah, so this is important. Okay, so the next one we're going to talk about is your probably one of the least favorite reaction patterns for me and even for like you guys is a suppurative granulomatous dermatitis. So suppurative granulomatous dermatitis by definition means infectious. What it means is that you have a good number of neutrophils almost forming an abscess along with a lymphohistiocytic granulomatous infiltrate. Now, it could be variable in location. The epidermis could be unaffected like this. It could be a deep-seated lesion, or it could even be subcutaneous, or it could be juxtaposed to the epidermis with hyperplastic epidermis with epidermal ulceration. So it could be variable. But the infiltrate itself has neutrophils in good amount. They look pretty dirty, like forming micro abscesses, along with the lymphocytes, histiocytes, and giant cells in the background. So this is what I always call like a very dirty looking pattern where you see both neutrophils percolating around. This almost always spells out infection. So in real life, when we deal with something like this, we know that we are dealing with an infection. So again, two possible scenarios can occur, right? The possible scenarios will be either you see the organism or you don't see the organism, right? If you see the organisms that you're most likely to see are going to be either Miyawki's granuloma, like deep-seated dermatophytosis, or things like mucor and stuff don't produce this. Or it could be like a deep fungal infection like Leish or histoplasmosis and Alternaria, like the ones that we are going to talk about. So either you see the organism. If you don't see the organism, then you are dealing with mycobacterial or atypical mycobacterial organism. That is like the most common cause of an invisible organism that is producing a suppurative granulomatous dermatitis. Now, mind you, classic conventional bacteria like staph or furuncles, they do not typically incite a granulomatous response. It's most oftenly like an abscess. Okay, very rarely they can. That is why but they're easy to pick up on culture. If you culture it, they'll grow. The problem is with the mycobacterial and the atypical mycobacterial organisms. So either you see it, in which case look for fungus, which could either be Miyawki's or one of its variants or a deep-seated fungal infection, which we will talk about. If you don't see it, that's when you think about mycobacterial and atypical mycobacterial infection. So in your boards, when they're testing you on a mycobacterial and atypical mycobacterial infection, it would be an invisible infection. You will not see it, but you will see the reaction pattern. When you see the reaction pattern, this is the organisms that you think about. Okay, it could be the classic tuberculosis, which comes in these forms, or it could be these, which could be atypical mycobacterial, Mycobacterium ulcerans, Burulli's ulcer, Marinum, which is your swimming pool or fish tank granuloma. Chiloni and Fortutum are the most two common ones. That's the most common soil pathogen which causes skin infection following contamination. So most of the atypical mycobacterial infections that you see are from this organism. This is very rare. that is your MAI infection. I've never seen it in the skin. And Kansasi, it's also extremely, extremely rare in the skin. It more commonly occurs in the lung and the lymph nodes. But these are the organisms. So what do? The second step that you would do is you would throw in a bunch of infectious stains. We always do a gram stain for bacteria. That's not going to pick up mycobacterial organisms. It's going to pick up conventional bacteria. You do a PAS, GMS, Grocut stains for fungus. You do your acid fast and fight stains. So those are the most important for mycobacterial and atypical mycobacterial organisms. If the stains are negative, which in most scenarios I have to say they are negative, you have to proceed with tissue culture. The tissue culture has to be a fresh tissue culture. So you have to repeat a biopsy and you have to send it to a lab that does fresh tissue cultures. And the tissue culture you should include in there that you are specifically looking for mycobacterial and atypical mycobacterial organisms because they need to be cultured on a separate media. If the culture doesn't work, you have to do PCR analysis. PCR analysis can be done from your paraffin embedded tissue, but it's very low yield. We often, the most high yield would be to do repeat a biopsy to do a PCR on fresh tissue. So that is now increasingly available. Initially, there were very few laboratories. One was in Seattle, actually, that was doing it. But now at WashU, but now I think Quest and LabCorp also basically do it. So that would be basically the next step to determine it. So let me show you the different kinds of reaction patterns that these can generate. So this comes in like a dermal nodule. And here you can see that it has even incited central caseation necrosis. So this is the same kind of dirty necrosis that you see in erythema induratum or nodular vasculitis. So remember when we did different kinds of necrotic fat, that is what makes you think about an infection. You can see that this is formed this kind of very neutrophilic debris with this dirty necrosis in the center. That's very indicative of mycobacterial, atypical mycobacterial infection with the lymphohistiocytic infiltrate, granulomatous infiltrate in the background. So you will again proceed with the stains that we talked about or with the algorithm that I talked about. This is another one. This was a patient with Mycobacterium ulcerans, actually. And you can see that there is an ulcer. This is an upside down. There is reactive pseudoepitheliomatous hyperplasia. And then you can see very dirty looking. There are neutrophilic microabscesses and then all this granulomatous infiltrate. So that's again going to make you think about mycobacterial and atypical mycobacterial infection. Okay, let me show you the fight stain. This is a fight stain. And this is extremely painful. It's my least favorite thing to do is to basically, you have to like be very patient. You have to analyze multiple tissue levels to be able to detect some of the organisms. So you can see here, like these pink staining stuff in the background, these are your mycobacterial organisms. It's an extremely, this is very, very consistent with mycobacterial, the slender kind of long pink organisms right here. This is it is very satisfying when you see it because you have really made the diagnosis, but most of the times it does not happen. Like we may find one single structure after searching multiple feeds. So it's a very tedious job to do, but it is very satisfying when you see it. So that's about your mycobacterial and atypical mycobacterial infection. Now let's come to your leprosy. So the leprosy, okay. So leprosy is also a mycobacterial infection. Things about leprosy is that you use a fight stain to detect it and you cannot culture Mycobacterium leprae. So culture is out of the picture, okay? You straight away have to go to PCR analysis. So it's either a fight stain or PCR analysis. The PCR analysis can be done from the paraffin embedded tissue. So you do not need to repeat a biopsy. You can repeat a biopsy, but you do not need to because you can do it off the paraffin embedded tissue. The leprosy has two spectrums to it. One is your lepromatous leprosy, where the body's immunity is extremely low. So the body will form exuberant, purely histocytic response with minimal inflammation. And the other end is the tuberculoid leprosy, where the body's immunity is very good. So you will form well-formed tuberculoid granulomas, very difficult to see the bacteria. So in lepromatous leprosy, you actually don't even need a stain. You can see the bacteria. But in tuberculoid leprosy, you do not see the organisms. You do have to do the stains, and most often you will end up doing the PCR analysis. So remember yesterday when we were talking about paraphenoma or sclerosing lipogranuloma, remember those holes and spaces we talked about in the tissue it produces? This is how lepromatous leprosy will look like. Lepromatous leprosy is another disease after granuloma facial, which is supposed to have a nice Gren zone, okay, a Gren zone. But honestly, yes, it is supposed to be present. Maybe we don't see enough of lepromatous leprosy, but it's not something which is diagnostic for that slide. But a Gren zone, like granuloma facial, has been described in lepromatous leprosy. So to me, in the slide of lepromatous leprosy will look on low power just busy, and you do not know what is happening. When you go up on high power, there is honestly a sheet of this empty cells, which are all histiocytes. Okay, but these histiocytes, what do they contain? Are these clumps of bacteria? So they are globoid cells. So does everybody notice that? So they look empty cells, like what I showed you in the sclerosing lipogranuloma yesterday, but the content is important. What is inside them are all these clumps of bacteria, which are your globoid cells. So you really don't need to even stain it because you can see the organism, right? You will obviously stain it. You will do a Phyte stain for confirmation, but this is pretty easy to recognize. So something that looks empty, sheet-like, and these how the globoid cells with the clumps of bacteria look like. Let me show you some other examples. This was a really, really nice case I had. This was a patient who was actually an Indian patient in Atlanta. And he was born and brought up, no, or maybe he was an immigrant, but not like a recent immigrant, like he had been in the United States like me for like 20 plus years. And he went on a ketogenic diet. And the ketogenic diet probably did something to his immune system, and he may have had the latent leprosy infection, and he kind of blew up in this eruption. So when this came to us, this came in with the I don't remember the clinical, but it was a non-discrete clinical. And you can see here that this entity has a very beautiful Gren zone. And in the dermis, you have the sheet of infiltrate, which are all histiocytes. And you can again see the globoid cells. You can see these clumps of fluffy bacteria in the lesion. This one has incited some degree of inflammatory response, so it's not perfectly lepromatous like what I showed you. This is more called a borderline lepromatous leprosy, but you guys don't need to classify what kind you're seeing, as long as you're able to see the globoid cells and identify them to be lepromatous leprosy. So this is a really nice case. Okay, so the other end of the spectrum would be the ones that we have talked about, and that is tuberculoid leprosy. So tuberculoid leprosy, the body's immunity is really good. So it will incite tuberculoid granulomas with this classic bag of worms, the expanded perivascular lymphohistiocytic infiltrates, like what you saw in syphilis, secondary syphilis, oriented perpendicular to the epidermis. Now, the difference from secondary syphilis is that these will basically not have that neutrophilic extravasation, very rarely, but they will certainly not contain the plasma cells. And also presence of perineural inflammation, which we do not see in this biopsy, is a really good hint. So if you see inflammation of a granuloma around a nerve, that's very indicative of tuberculoid leprosy. So, so the second step in this would be to do a Phyte stain. You will have to do it on multiple levels to be detecting one single organism. The more successful technique would be a PCR technique. Okay, so that is about leprosy. Now, things like, you have things like, so these are your must-know slides, lepromatous and tuberculoid leprosy. Things like E. nodosum leprosum and Lucius phenomenon, they are reversal reactions that will occur. So like Lucius phenomenon is essentially LCV. So it looks indistinguishable from your classic leukocytoclassic vasculitis. So these entities, they are most likely wrong answers. Unless and until they are giving you a specific clue in there, you will not be tested. Or they are like these, they are spectacular case reports to write about, but they are most often distractors on your board. But these are an absolute must know. Okay, now let's move on to some of your parasitic infections. So arthropod assault or parasitic infection. So let's start with the most common one, that is scabies. Yeah, the thing that I wanted to tell you is that the two diseases which are always on my radar, if there is a discorrelate between the clinical and the histology, it's scabies and leprosy and syphilis. So scabies is again a great masquerader. You guys may not be thinking about it, and it may be as simple as scabies. So trust it when the pathologist tells you that this, make sure it's not scabies, that you're making sure it's not scabies. So I have had cases where they really think it's an immunoblistering disease, and they submit it for a DIF, and and the histology shows scabies, and the DIF comes back positive. So which is a false positive DIF. So scabies is again a very notorious masquerader, very simple disease to pick up. You have to be persistent with it. Okay, so this is the classic scabies. You can see that this is where it locates. This is the burrow. It's beneath the stratum corneum. You can see the organism. In the dermis itself, there is going to be a perivascular lymphocytic infiltrate, which has a lot of eosinophils. This is the pattern of papillary urticaria. When we call something papillary urticaria, we are referring to an arthropod assault, which is basically a perivascular lymphocytic infiltrate with lots of eosinophils. And in this instance, you can see that the nice organism is located beneath the stratum corneum. This is the nice location for scabies. Okay, so let me show you more. Sometimes you may not, get the entire perfect organism. You just get portions of it. This is a nice example of Norwegian scabies where you see multiple scabies mite in one section. So it's kind of like disgusting to look at, but you can see, and again, this entity, Norwegian scabies, is also a great masquerader. It can mimic psoriasis. It can really fool one clinically. So you can see the nice scabies mites beneath the stratum corneum. And for scabies infestation, you have to make sure that you're looking at, when you are provided with the slide, make sure that you look at all the levels, because the scabies may be present in only just one level. Okay, so the next one is, I just want to show you this. This is an example of an engorged tick which was stuck to the patient's skin. This is how disgusting it looks like. You can see the entire tick in its glory. It has been mounted on this slide, so it's a beautiful section. Okay, the next organism which can mimic scabies infestation is cutaneous larva migrans. So I think it's Ankylostoma brasiliensis. So the reason it mimics scabies infestation is because it can also incite a lot of inflammatory response with eosinophils. So the best place to pick up the organism is when you see the creeping eruption. And that's the best place. And that will most often occur on a part that has been exposed, so like the acral side. So here you see that the biopsy on low power really looks like dyshidrosis, dyshidrotic eczema. When you go up on high power, there are a ton of eosinophils in the biopsy. So this is how even scabies can look like. The location for cutaneous larva migrans, even though the organism can look very much like scabies, the location is different. So the location, it penetrates through the stratum corneum and is located in the superficial stratum spinosum. So you can see here beneath the stratum corneum. Scabies never gets that deep. It doesn't live there. This has to eventually go into the skin deeper down, right? Scabies doesn't do that. It just digs a burrow in the stratum corneum, and that's where it lives. So if you see it beneath it, that's not scabies. So this is Ankylostoma brasiliensis or cutaneous larva migrans or the creeping eruption. Okay. The next one is going to be myiasis. So it has now come completely dug inside the skin and is living deeper down. Not this one, sorry, the wrong slide. Here. So myiasis, which is your maggots, the fly laying their eggs in the skin. What is it called? Dermatobia hominis or something. You should know the name for it. So it produces a lot of destruction in the skin, and it actually produces almost like a tract within the skin, and that's where it likes to live. So you can see all these the larva producing lots of tissue destruction, inflammation, necrosis, and being laid in the skin. Now, this is going to be different from Tanga penetrans. So let's talk about that. So I don't have a slide for it, but I do have a PowerPoint illustration for it. I think it's towards the end. So, so we are coming into the differential diagnosis of the big structures that you see in the skin. So tungiasis or the tunga penetrans, it's a gravid flea which will basically burrow into the skin. Tunga penetrans likes to communicate with the stratum corneum, whereas myiasis doesn't. So it digs a hole deeper into the skin and surrounded by all that inflammatory necrosis. Tunga penetrans doesn't do that. It doesn't incite much of inflammatory response. It has dug its hole and it's communicating with the stratum corneum. And this is tungiasis or tunga penetrans. It's a gravid flea. Other big structures are onchocerca, which is your microfilarial organisms, which cause this classic leopard skin. This will look like filarial worms, which have again, they look like little big eggs, which are dug into the skin. This is how they look like. So they look like little worms present in these kind of pseudocystic structures inside the skin. The next big one is cysticercosis, which is your tinea solium. This is common in developing countries. When you have the intermediate host is the pig. So when the feces with the eggs get deposited on like plants and vegetables, they are ingested, and this can result in formation of these structures which can go into the brain or even into the skin. So this looks like a worm. So you can see the entire organism. So this looks different from microfilaria. So this is cysticercosis. What I'm not illustrating to here to you guys is schistostoma. So that's your homework. So completion of this would be schistostomiasis. So I want you to go back. There are 3 different kinds, and I want you to look and compare it with how they all look like. So the big organisms that you see, the smaller ones are scabies and cutaneous larva migrans. The bigger ones are myiasis, tunga penetrans, microfilarial, which is onchocerca infection, and your cysticercosis and schistostoma. So I want you to go up and I want you to pick up schistostoma and put different pictures of this, to basically memorize it in your memory. Another big organism, which is not a parasite, is actually a deep fungus, is Rhinosporidium. But just for the sake of the size of it, I want to talk about here. So Rhinosporidiosis. Don't confuse this with Klebsiella rhinoscleroma infection. That's a bacteria, okay? This is Rhinosporidiosis. It's more common again in India and Sri Lanka. It's a waterborne infection. So when they ingest the dirty water, it's a dustborne and a waterborne infection. It will produce you these polypoidal masses in the nasopharynx and in the conjunctiva if the water gets in there. And these are really big. They are easily recognizable. So you can see these thick walled sporangia, which will contain these spores. Okay, so that is rhinosporidiosis. Don't confuse this with rhinoscleroma, Klebsiella rhinoscleromatosis, which is different, which produces this muculic cells in the plasma cells, which again is in this PowerPoint. So I want you to go back and, look at those slides. So this is rhinosporidiosis. So these are the big organisms in your differential diagnosis when you see them. Okay, so do you guys have any questions till now? Okay. So let's now move along to your fungal infection. So fungal infection, dermatophytosis, the superficial tinea fungal infections are the most common, our bread and butter. We see them almost on a daily basis. Tinea in its classic form is very inflammatory. So it will produce you again a subcorneal blister with neutrophils, or a dirty neutrophilic crust. So whenever you see neutrophils in the stratum corneum, especially when they look very dirty, there is you see neutrophils coming out, but associated with all this debris and dust in the stratum corneum. That's very indicative of tinea infection. And the classic tinea, it will produce you a sandwich sign. So the organism is sandwiched in between these dirty layers of stratum corneum. So the trick is to go into the area where either the stratum corneum is lifted up or adjacent to it, wherever it is dirty. And here you will see them as translucent spores or hyphae. These are pseudospores because this is the fungal hyphae has been cut off in a different angle to produce these empty spaces in the stratum corneum. And this is how it will look like. So you can see these spaces and holes in the stratum corneum. There is more here. So this is your sandwich, and you can see how they are, sandwiched in between the layers of the stratum corneum. So that is your tinea infection. Obviously, with the PAS stain, they are very easily recognizable, but they're not going to be so kind to you as to give you the PAS stain, because that will make it super easy. Now, this is going to be in contrast to your tinea versicolor infection, which is not going to be super inflammatory at all. So it is going to be an invisible dermatosis. So when you see tinea versicolor, again, a very important board slide, it will incite no inflammatory response, but it's easy. When you invisible dermatosis, you go from top to bottom, and within the stratum corneum, you should be easily be able to see the organisms. And they do not incite an inflammatory response, and you see them. So they look like blue fungal hyphae and spores. These are true spores, yeast forms with the fungal hyphae forms. So your spaghetti and meatball appearance. So you can see the nice tinea versicolor. You know, it's very easy to identify. But remember, you have to distinguish this from Candida. So Candida doesn't have true hyphae. It is a yeast. So it will have pseudohyphae and spores perpendicular, but with a lot of inflammation. So we'll talk about Candida, but that's going to be its closest differential. So no inflammation is tinea versicolor, lots of inflammation is Candida. Okay. Tinea nigra is also very, is one of those diagnoses which is very satisfying. Most often this will come in, you're not suspecting it. It will always come in as a melanocytic neoplasm. It is again, like tinea versicolor, not very inflammatory. But when you look up in the stratum corneum, it's going to be loaded with pigmented fungal hyphae. So you can see that. So pigmented fungal hyphae with minimal inflammatory response is tinea nigra. Okay. Before going into Candida, I'm going to talk about Maiocchi's granuloma. So Maiocchi's granuloma and tinea capitis, you are both looking for the same thing. So Maiocchi's granuloma is basically going to be infection of the hair shaft, which then incites an inflammatory response around it. So that is why it is more deep-seated. Okay, so it produces you either nodules or plaques, which are more deep-seated. So they will be suppurative and granulomatous dermatitis. It's going to be in the path of a follicle. And the key is to identify the infected hair shaft. So the problem with Maiocchi's granuloma is that when sometimes you guys biopsy it, you may not biopsy the infected hair shaft. So imagine you're biopsying a nodule or a plaque, you may go into the pus area where there is suppurative granulomatous inflammation, but you may miss the infected hair shaft. So based upon when we look at the biopsy, based upon the reaction pattern, we sometimes really think, oh, this is a deep-seated neutrophilic infection. It looks vertically oriented in the path of a hair follicle. This is likely Maiocchi's. We're not able to see the organism. Then we will often request you repeat a biopsy because that can be very high yield. So what is happening in Maiocchi's and tinea capitis, even though they are different diseases, is you're looking for the same thing. You're looking for an infected hair shaft. Now, believe me when I tell you guys this, that it should be very easy to see, right? It's an infected hair shaft. It's one of the first thing you guys will ignore. It will be right in front of your eyes and you'll be like, nothing is happening. Not only you guys, I have seen very experienced dermatopathologists completely blowing it off. The first time I saw it in my career, I blew it off. So now for the next 2 minutes, I'm going to show you a bunch of slides to show you how an infected hair shaft looks like. And I want you to bury that picture in your head because the diagnosis is very simple, but it is very easily ignorable. So both Maiocchi's and tinea capitis, remember, you're looking for the same thing. So this is an infected hair shaft. So you see this, the spores and the hyphae inside the hair shaft. I'm going to show you a bunch of pictures, okay? And trust me when I say it, you may think this is super easy. You will blow it off when you see it in real life. So this is Maiocchi's. So let's go to more examples. This is again a nice little fungus living inside the hair shaft. This one, see how in multiple slide sections, just like your scabies, you have to look at all the slides. You see how easily it can be ignored because your eyes will catch the trichohyline granules, but this is the fungus right next to it. You can see the fungus in there. You don't even need a PAS stain. Maiocchi's is so beautiful that you can actually recognize it if you are thinking about it. If you're not thinking about it, your eyes will miss it. So again, this was more of tinea capitis, but it was again the same. You can see the beautiful fungus in there, in the hair shaft. This one is a little bit more subtle, but these are all fungus in the hair shaft. Okay. The next one is another one. This is the last one I'm showing you guys. Whenever you see free-floating hair shafts in the skin, make sure that you're looking for fungus. So you see this. This is a beautiful Miyawki's granuloma. This entire hair shaft is broken up and filled with the organisms. Okay, so this is what you're looking for in Miyawki's and Tinea capitis. You're looking for the infected hair shaft. So keep your eyes open and your brains open to think about it. Okay, so now we're going to talk about Candida. So Candida infection is one infection that is super inflammatory. It's even more inflammatory than your conventional tinea. It even goes one step beyond conventional tinea because it can incite hyperplastic pseudoepitheliomatous hyperplasia. So I have seen cases, especially in the lip region, misdiagnosed as cutaneous SCCs when it's just Candida infection. So it can be very, very inflammatory and incite a lot of pseudoepitheliomatous hyperplasia. The reaction patterns it can produce is psoriasiform and lichenoid. So you can see that it on low power, this almost looks like inverse psoriasis. It's a lichenoid pattern. It's very easy to see again because you don't need the stain. You can actually see the organism. So they look like Tinea versicolor, but not really Tinea versicolor because it's much more dirty. And you can see how these pseudohyphae are oriented perpendicular to the epidermis, and on top, there will be the clusters of the spores. So I'm going to show you some bunch of slides of Candida again. So you can see here how inflammatory it is. So let's see more examples of Candida. So in this particular scenario, you can see how dirty it looks, the stratum corneum. There are tons of neutrophils, lots of psoriasiform hyperplasia, and these are the organisms in here. Hold on. So you can see here how they're oriented perpendicular to the epidermis. These are the nice spores, and these are the pseudohyphae because these are all produced by the spores. So it's a yeast. So this is what makes it. Okay. The next one is going to be another example. In this scenario on low power, this is from the mucosal cavity. You can actually see that it really looks like lichen planus. That's what I'm thinking about on low power. But when you go up on high power, you can again see these perpendicular structures oriented perpendicular to the epidermis. Okay. Another one that I'm going to show you, this is the classic example where you can easily call it a squamous cell. You can see how much of atypia and reaction it has produced, but you see how it is so dirty in the stratum corneum, and you can start seeing all these organisms oriented perpendicular to the epidermis. And when you see the spores on the top, that's like pathognomic. You can see these spores and you can see the organisms perpendicular to it. So that is all candidiasis. So that is verrucous candidiasis. Okay. So that is about your superficial fungal infection. So superficial dermatophytosis, right? So that under that is Tinea, Miyawki's, Candida. Make sure that you know the second order questions as to what is the most common Tinea causing Miyawki's. Okay, so you know all those. You need to look those up. Common causes of Tinea capitis and stuff like that. Let's go to your deep fungal infections now. So your deep fungal infections, so how are we going to approach them? So when you look at your deep fungal infections, and I'm going to share this PowerPoint with you guys, this is how you're thinking about it. You are, why did this happen? I don't know why this is here. Okay, so when you look at a deep fungal infection, the two things that you have to broadly do in your mind is this pigmented or is it not pigmented? Because that was going to put you in a completely separate category. Okay. This is when you're seeing both hyphae and spores. Okay. The yeast forms are different. When you see the yeast forms, then you are going to be in this category. When you're seeing a deep fungal infection with the hyphae and the spores, then you're thinking to yourself, is it pigmented or not pigmented? If it's a pigmented fungus, it's most common caused by secondary implantation from a trauma, and that's called a dematiaceous fungus. So pigmented fungus is a dematiaceous fungus. And a dematiaceous fungus could be chromoblastomycosis if it just has the spores, pheohyphomycosis if it has both, and alternaria. Okay, the most common ones that we encounter are chromo and pheohyphomycosis. Alternaria will look exactly like pheohypho, except that it occurs in immunocompromised individuals. So look for clues in your when they're asking you the question: is the patient immunocompromised? Is it a burn patient? Is it a patient who is with leukemia, has had a bone marrow transplant? So things like that. So pheo, chromo, and alternaria, these are all dematiaceous or pigmented fungus. If it's not pigmented, then it could be mucor, aspergillosis, or fusariosis. Mucormycosis and aspergillosis, you can distinguish them from one another. Both these ones, mucor, aspergillosis, and fusariosis, so these ones are very inflammatory. They incite a lot of inflammatory response. Mucus, aspergillosis, and fusariosis, they are typically not very inflammatory. Okay, and they can also be vaso-invasive. So that is a problem with them, and that's why they are very important diagnosis to make. Mucor and asper, you can absolutely distinguish based on the histology, and we will talk about. Aspergillosis and fusariosis, you cannot. So they will look exactly similar. Again, fusariosis occurs in immunocompromised individuals in certain scenarios. So again, look for those clues that they are tending to ask you. Okay. So with that, let's see a few examples of each. So dematiaceous fungus, we talked about when I showed you a splinter. Its most common cause is a foreign body. Most common cause is the site of a trauma. So it will not be uncommon that you see a scar and you see some kind of a polarizable foreign material, milia formation, and then in the background of it, you see these pigmented hyphae and spores. So that's dematiaceous fungus. So you can see these pigmented hyphae and spores. That's your dematiaceous fungus. It can occur superimposed on the top of a splinter. So that is probably one of the most common scenarios that we see it in. So you can see here. You can see here there is a splinter, and this is the fungus superimposed on top of it. These, generally do not even require treatment, because if you get the splinter out, so you can see the splinter in here. If you get the splinter out, the organism will basically come out along with it. The problem with the dematiaceous fungus and pheohyphomycosis is when it forms like an inflammatory response, like a suppurative granulomatous dermatitis, and then you have to go in the organism to basically to be able to look for that organism. So, that becomes a little bit more tedious. So, for example, in this case, so here it has incited a nice suppurative granulomatous dermatitis, but again, super easy to see because you're seeing the organisms. You can see these pigmental fungal hyphae and spores. This could be pheohyphomycosis, or it could be alternaria. So they will look exactly similar. So again, you have to ask for the second order questions, what they're asking you. So both pheohypho and alternaria will look like this. That's the pigmented fungal hyphae you are seeing. It can even be a little bit more subtle. So this was in an immunocompromised patient. You can see how nicely it has incited a bit suppurative granulomatous dermatitis. So this is the one where you will approach it. Either you see the organism, you don't see the organism. So you just have to dive into the most inflamed area, and you can, everybody sees those pigmented structures. Pheo and alternaria are easy to see because they are pigmented. So you can see them as long as you know what you're looking for, right? So you're looking for the deep fungal, pheo, hypho, chromo, and the non-pigmented ones, which we will talk about. So this is your pheohyphomycosis or alternaria. They will look similar. Chromoblastomycosis is pretty easy to recognize. And I think that's one of the infection organism which is, you guys recognize it most easily. Remember that chromoblastomycosis is very, very much inflammatory and incites a lot of pseudoepitheliomatous hyperplasia. So very often these lesions come in as cutaneous SCCs and you're not thinking about it. But when you see it's very easy to recognize. You can see these copper penny bodies. So it is only spores. You do not see the hyphae. So if you see the hyphae, you will call it pheohyphomycosis. So these are your nice copper penny bodies of chromoblastomycosis. So you guys are very good at recognizing this. Now let's talk about the non-pigmented fungal hyphae, deep fungal infection. So that is mucor, aspergillosis, and fusariosis. So typically mucor aspergillosis, they are not that inflammatory, but they will produce you lots of ischemia and tissue necrosis. So you will almost get like a dead skin, which is not very inflammatory, lots of hemorrhage within the lesion. And these are the organisms. So you can see in here, these organisms. So these are not pigmented. These are very aseptate and they are broad, ribbon-like. That's mucor. So aseptate, non-pigmented will be both mucor, aspergillus, and fusariosis. But mucor is very broad, aseptate, the broader angle branching, but more easy to recognize is they're more like ribbon-like, broad, haphazardly arranged, not really branching very well. That's going to be indicative of mucor. And mucormycosis can be, your Apsidia or Rhizopus. They all form in that category. So this is your mucor infection right here. Aspergillosis and fusariosis, I'm going to show you in my PowerPoint slide. They are much more well-defined. So this is aspergillosis. This is the H&E, and this is the GMS stain corresponding to it. You can see that the aspergillosis, these are much more slender, and they are often septate, and they have an acute angle branching. They have a more acute angle branching. So both aspergillosis and fusariosis will look similar. So you cannot distinguish it. So this is aspergillosis. So different from mucormycosis. Okay, so now let's go into your deep fungal infection where you're predominantly going to see spores. And in this case, size matters. So this is how you're going to memorize it. This is in the increasing order. So the smallest ones are Leishmania, histoplasmosis, and penicilliosis. All these three things, they are of the same size. And penicilliosis looks exactly like histoplasmosis. You cannot distinguish it again. Penicilliosis versus histoplasmosis. But penicilliosis again occurs in neutropenic patients. So you look for certain clues that they are asking you to detect penicilliosis. Then comes cryptococcosis, blastomycosis, which is equal to size to lobomycosis, and you have coccidio and paracoccidiomycosis. Okay, there is another organism which I didn't put in here, which is your, which is the one that occurs in the lung. What is it? Pneumocystis carinii infection. That looks like cryptococcosis. So like when you're going through this slide, remember, put cryptococcosis equals pneumocystosis carinii. You guys know, right? That's the PCP pneumonia. That's the infection that occurs in it's an AIDS-defining illness. It more commonly occurs in the lungs, but it can also occur in the skin. Can somebody tell me there's a specific terminology for it when it occurs in the skin? Does it cause your otitis externa? You should look it up because that's an important board question. It has a specific infection it produces in the skin. So cryptococcosis equals pneumocystosis. So when we talk about cryptococcosis, I will show you a slide of pneumocystosis. Okay. So Leishmania, histoplasmosis, penicilliosis, then cryptococcosis, which equals pneumocystosis, blasto equals lobo, coccidio, and paracoccidio. These organisms, Leish, histo, and penicilliosis, they often produce what are known as parasitized histiocytes. They are so tiny that histiocytes will ingest them. So sometimes they look like in clusters, filling up and expanding a histiocyte. So the term parasitized histiocytes is often referred to these infections. Okay, so now let's look at these infections and try to recognize them. All of them are super important, and you will get them, one or the other you will get in your boards. Okay, so all of them are super inflammatory except for cryptococcosis. So except for cryptococcosis, all of them are going to incite a dense inflammatory response, which is suppurative and granulomatous with variable degree of epitheliomatous hyperplasia. The most degree of pseudoepitheliomatous hyperplasia is incited by, we already talked about chromoblastomycosis, right? The next ones will be blastococcidiomycosis. Blasto and coccidiomycosis produce you a lot of pseudoepitheliomatous hyperplasia as well. Okay, so this is a very inflammatory biopsy. You can see suppurative granulomatous inflammation. You're going to dive deep down. And at this power, do you see this large structures in here? I'm already at 45x. So size really matters, you can see. But do you see these large structures in here? These fluffy structures, these are parasitized histiocytes. Okay, so inside these histiocytes will be the organism. Okay, so when you see these parasitized histiocytes, the three things you're thinking about are histo, penicilliosis, and leishmaniosis. So histo, leish, and penicilliosis is what you're thinking about. So you have to distinguish between all the other. Remember between those three. So remember that histoplasmosis and penicilliosis will look exactly similar. So for histoplasmosis, you're looking for the capsule, Histoplasma capsulatum, right? That's what its name is. So if you get a vague hint that this is the organism, I'm at 80x. You can see the organism which has a capsule around it. You can see these organisms with these capsules, organism capsule around it. That's Histoplasma capsulatum or histoplasmosis, but can also be penicilliosis. So you have to look for what question that they are asking you. Okay, so that is histoplasmosis. Now let's go to the next one, which is your leishmania. So again, leishmaniasis can be the new world or the old world. They will both look similar. You can see the nice dense subepiganomatous response. You have to just dive into it. And again, at low power, do you see these kind of stuffed up histiocytes, the larger, these stuffed up histiocytes? Does everybody see that? So these are called what? What are these stuffed up histiocytes called? One of you unmute and tell me.
Parasitized histiocytes?
Yes. So parasitized histiocytes. So when you see that, you're thinking about 3 organisms. So now let's go in and see the organism. So you see this organism, instead of looking at the capsule around the organism, you're looking that it has a prominent darker edge to it, right? That's your safety pin appearance or kinetoplast. So they look like little safety pins with the kinetoplast. That's leishmania. So you see the difference? In histo, the capsule looks prominent. In the leishmania, the nucleus or the kinetoplast looks prominent. So you can see these little organisms, right? Now, another thing leish does, which typically histo and penicilliosis does not do, is that inside these parasitized histiocytes, this leish, it sticks like the spokes of a Ferris wheel. It sticks to the inside boundary of the histiocyte. Typically, histo will not do that. So that's another sign that you are dealing with leish instead of histo or penicilliosis. Okay, but all of them are producing parasitized histiocytes. Is that good? So remember that the reaction pattern is important, because when you're looking at this suppurative pattern, you're not really going to look for crypto or pneumocystosis. Okay, and then when you go up on high power and you're seeing parasitized histiocytes, you're not really going to think about blasto and coccidio and paracoccidio. They're too big. So this is how you're narrowing down your differential as you're moving into the slide. Okay, the next one is going to be cryptococcosis. So cryptococcosis is the next size. We're going by size. So cryptococcosis is not very inflammatory. It actually looks like an empty kind of a slide because it produces you kind of like pools of mucin sometimes, and you will see the organisms floating around. So when you go up on high power, the organism is significantly bigger. So it's not within histiocytes. It's a whole organism on its own. And these are the organisms that you're looking for. Do you see this? These are also encapsulated. They have a capsule around them, which you can highlight using the mucicarmin stain. It's a mucin-containing capsule, and that's why it produces the gelatinous background. They look sometimes like this concave structures or canoes, little boats. Okay, this is exactly how pneumocystosis will also look like. But that's going to be in the lung. It can occur in the skin, which you're going to look up and tell me what kind of infection it produces in the skin. So you can see these needles. So these are in their spaces itself. They're not within histiocytes. So this is Cryptococcus. So you can see these little canoe structures in the pools of mucin. They have a mucinous capsule, which is your mucicarmin staining. They can be budding as well in here. So that is cryptococcosis, and pneumocystosis will also look similar. The next one is going to be your blastococcidio and paracoccidio. So blastococcidio and paracoccidio are super, super inflammatory plus pseudoepitheliomatous hyperplasia. So they produce you a lot of reactive hyperplasia. The best place to look for blasto is actually in the extruded crust, so in the superficial part of the biopsy. The spores of blasto, they're very likely to be extruded through the epidermis, transepidermal elimination. That's your best place to actually look for them if you're suspecting blasto. And then if you don't see them there, then dive deeper into the infiltrate. But that's the best place. So again, on low power, you can, if you are in short for time, then you can look at those certain clues and try to narrow down. So you can see a super pseudoepitheliomatous hyperplastic biopsy. So these are the organisms. They are not going to be parasitized again. And you see them, they are these double encapsulated budding yeast forms. Okay, broad-based budding. Sometimes you may not see the broad-based bud because it kind of like gets broken down. Now remember that a paracoccidio is a big organism. When it gets broken down, the big one, it can look like blasto. So sometimes it can be very challenging. So that is why, again, look for the geographical region they are talking about. What is the question that they are asking you? Okay, so this is blasto. So I'm going to show you some more examples of blasto. So again, it is going to be super inflammatory, and it most often incites a very dense hyperplastic response, the best. You can see here marked pseudoepitheliomatous hyperplasia, and you can see the extruded crust. And the only place where I found the organism in here was in the extruded crust. So you can see the organisms in here. You can see here it is budding. You can see the double refractile wall. This is blasto. Okay, so show you another example. This is one of our patients that we have has chronic blastomycosis. So he always presents with these deep. This is an uncommon pattern for blasto to present like without the pseudoepitheliomatous hyperplasia, but this was nice organisms. He always has blasto in it. This is not like perfect for blasto, so forget about it. The first two ones that I showed you is perfect for blasto. The next one is coccidio. So coccidiomycosis, again, markedly hyperplastic. You can see marked pseudoepitheliomatous hyperplasia. Again, look for the more superficial places to find the organism. Coccidio is very nice because it looks like a really big egg, a big spherule which has endospores inside it. So it looks like a big thick-walled egg or a spherule with endospores inside it. This is coccidio. Paracoccidio will actually have the spores outside it. That's why it looks like a mariner's wheel. Okay, so I don't have a nice histology slide, but I have it in my PowerPoint of a paracoccidio. So let me show you that. But that is why to see it in its intact form is very rare for paracoccidio. So you see this? So what will happen is that this gets broken down, and you can see that these individual broken down look like what? Blasto. You see that? That is why what question that they're asking you is important. I did not talk about lobomycosis. So let's go to lobomycosis. Lobo has a very classic clinical and a very classic morphology. Spelled it wrong. Really? What is this? I spelled it wrong. Yeah. So everybody knows about the keloidal scarring it produces and the bottlenose dolphins, which are the natural habitat of these organisms. And so they look like blasto, except that they are long chains connected by tubules. So they look like tubular structures which are connected to one another. But the individual ones are the same size as blasto. And they're going to occur in the background of this keloidal scarring. That's when you think about lobomycosis, it's the same organism. One thing that I did not talk about is the sporotrichosis. So sporotrichosis is a not an uncommon deep fungal infection that you guys see. It is one of the most difficult organisms to identify on a routine histology. Most difficult. I actually have seen it in only one case, but it is the most easiest organism to culture. Okay, so I'm going to show you sporotrichosis. The thing about sporotrichosis is one of the ways to recognize it is through obviously the clinical. the sporotrichoid distribution. This is what you're looking for. The best way is to culture it. The culture is super easy, and right on the culture within a few days, you can see these cigar-shaped yeast. So that's the buzzword for sporo. It's a cigar-shaped yeast. And it's these cigar-shaped yeast, these tiny, tiny structures that you're looking for in the biopsy, which are extremely difficult to find. Honestly, there is one case that I'm going to show you, which I had, which we could detect it on the GMS stain. But to recognize it based on your histology is very difficult, because you can see that these are these tiny yeast, cigar-shaped yeast that you're trying to identify. So you look for the reaction patterns. The reaction patterns is the sporotrichoid clinically. On histology, it produces you a classic pattern of zonation. So you see a neutrophils with granulation tissue and then the histiocytes. Okay, asteroid bodies can be seen in. So these are the organisms that you're looking for. This is like a perfect example. We've never seen these many. Okay, so asteroid body is a reaction pattern that you see in response to, it is not the organism itself. So let me show you a slide of sporotrichosis. A minute. Yep, here. So this is your GMS stain. You see these structures right here, this structure? That is sporotrichosis. So you can see its size. It is significantly smaller as compared to blasto or coccidio. It's almost the size of the spore that you would see in, say, Candida infection, except that it's not on the top, it's deeper down. It doesn't have any pseudohyphae and it is budding. So it's a very, very tiny organism that you're going to be seeing in sporotrichosis. Okay, so that is your deep fungal infections that they test you on. Let's go to viruses. Viruses are going to be are easy. We'll start with the most simple one, which is your biggest virus, which is your molluscum contagiosum, the pox virus. It will nicely produce you these kind of pale-looking epithelial recess, and you will have the molluscum bodies, which are intracytoplasmic, the Henderson-Patterson bodies. So I don't think so you guys, any of you have a problem recognizing molluscum. Your HPV infections, which are your common HPV infections, and then your genital HPV. So you have your verruca vulgaris, and then you have your genital HPV. In the PowerPoint, there is a list of all HPV viruses that you have to know about, like, esoteric, even the butcher's wart and things like that. The HPV strains that they like to test you on, it's there. It's there in this PowerPoint. It's a list of your HPV different types. So you need to memorize that. The classic common HPV is verruca. This is verruca vulgaris, which is HPV 3 or 2, I forget. But you have to recognize it with the chyliocytes, which is this kind of fish-eyed granules. They look like hypergranulosis, but they are more distinct. They are the clumped infected keratohyalin granules. I think this is good for you guys. The palmoplantar wart is your myrmecial wart, which is HPV 1 and 2. Instead of producing those pink granules, it will produce you blue granules. It will produce you the pink infected granules. So you can see these. It also has the hypergranulosis, but they look more pink as compared to blue. And it is more of like an endophytic wart instead of exophytic. So that's your myrmecial, your palmoplantar verruca. The verruca plana, which is a very important board question, which is your HPV 3 and 10, is going to be a flat wart. So this can be a little misleading because this can look like either epidermodysplasia verruciformis. What else do you guys confuse this with? EHK, epidermolytic hyperkeratosis, is another thing that you guys confuse it with. Notice here that the stratum corneum is artifactually lifted, which it can. It is not a blistering disease. So this is very easy to recognize, but it can be a misleading slide. And what you're seeing is a flat. So there is no verrucous hyperplasia, but you're looking for the same fisheye, the same hypergranulosis, the same clumped keratohyalin granules with this perinuclear vacuoles around it. So that is verruca plana. Epidermodysplasia verruciformis, which is your HPV 5 and 8. It is a pre-malignant HPV infection. This will look like this collection of keratinocytes, which will have the steel gray cytoplasm, which are superficially. So you can see this right in here. That is epidermodysplasia verruciformis. Genital HPV, which could be your low risk or your high risk HPV, could be your classic condyloma. So condyloma, unlike your verruca, they're more flat. They can be warty, but most often proliferation is in the background of like a seborrheic keratosis. So it can look like a sepke. But when you go up on high power, you are seeing the coilocytes, which have racinoid nuclei. So they look like little raisins. This is classic for HPV, genital HPV infection, where you can see the perinuclear vacuoles and these clumped up nuclei. So it doesn't produce you a lot of hypergranulosis like verruca vulgaris does. These are your coilocytes of your condyloma. This is almost a low-risk HPV infection, so 6 and 11. Though you will have to type it, you can do it by in situ hybridization testing. So you will have to request for that. We can just tell you whether it's condyloma or not a condyloma, or whether there is an associated malignancy with it. When there is an associated malignancy, it by definition is a high-risk HPV, which is 16, 18, 31, and 32. Okay, this is an example of Bowen's disease arising in association with the condyloma. This is your classic condyloma. So you can again see, this is what you're looking for, these kind of racinoid nuclei, which are classic for HPV infection. This is undeniable. So if you want a wart in it or you want like a sepke in it, this is not. This is condyloma. I was trying to show you the Bowen's disease arising within it, which is going to be, give me a minute, I will trace the slide here. So here you can see it is more in a flat pattern, but you can see that there is full thickness epithelial atypia. So this pattern of full thickness epithelial atypia in a genital area is invariably associated with high risk HPV infection. So that is SCCIS arising within, it's not, I wouldn't say within a condyloma, because when you're using the word condyloma, you're meaning a low risk HPV infection. So this is high risk human papillomavirus infection induced SCCIS. This can occur in the genitalia. It can occur even on your hands. The next one, the next virus is going to be your ORF. We have again talked about it. You do not see the viral inclusions in ORF. You recognize it with the reaction pattern, which is your ballooning reticular degeneration. So ORF, which is your parapox virus infection, which could be ecthyma contagiosum or bovine papillary stomatitis or ORF, or your monkeypox infection, they're all going to produce the same reaction pattern, which is this ballooning reticular degeneration. So a lot of fluid, a lot of dermal edema, a lot of fluid inside the cells, in between the cells, they will swell up and blow up like a balloon. And you can see this kind of reticular lacy outline, which is left behind. So this is the pattern of ballooning reticular degeneration in your ORF infection, ORF, ecthyma contagiosum, bovine papillary stomatitis, or monkeypox. So you have to look for the second order question that they are asking you. Then we are coming to an end. So the herpes infection. The herpes infection, again, based upon the histology, you cannot distinguish between HSV1, HSV2, varicella, which is chickenpox or zoster and shingles. They will all produce you the same viral cytopathic change. To call something herpes infection, you have to see the viral inclusions. So the biopsy of herpes infection is very variable. It's almost always very inflammatory. So you can get superficial deep inflammation, which could be very dense. You often get acantholysis, so it can mimic a blistering disease. And what you need to see are these cells with the classic viral inclusion, which are your 3 M's, which is your multinucleation, nuclear molding and margination of chromatin. So you need to see this viral inclusions to be able to call it that. That's your herpes infection. And then lastly, I'm going to briefly talk about a mycetoma. So a mycetoma is essentially a fungal ball. And the fungal ball, there is a PowerPoint slide on actinomycosis, the things that you need to know about actinomycosis, and what's the other one that you need to differentiate it from, nocardia, as well as the discharging draining sinuses, which is your Madura mycosis, these granules and these grains. It's a very beautiful PowerPoint slide, so go through it. They are very high yield. This slide you need to memorize based upon the color of the grains that are extruded, like what organism are you looking for. But what do you mean by a grain? A grain is a triad of abscess, sinus. So a mycetoma is a triad of an abscess, sinuses, and the grains. The grains are clumps of the fungus, okay, or the organism. So this is when you think about a mycetoma. So you see here lots of ulceration, abscess, neutrophils. It looks like complete destruction. And within that destruction, you're seeing these clumps of organisms, which are all your fungus in here. So none of the organisms that I talked about right now in your fungus are going to produce this kind of a triad. When you think about this kind of a triad, that's a mycetoma. And then you need to classify it further as to, what is that fungal infection, which is what this slide is talking about. Could it be, it's not good, filament, that's not how a bacteria will look like, right? That's a fungus. This is obviously not a bacteria, but bacteria can also produce these grains and granules. So you need to know the names of these organisms. When you see the fungus, that is what it can be. So this is what you need to memorize. Okay, and then there are some esoteric infections in there. So I'm going to share this PowerPoint with you. If you guys have any questions, you let me know. But they're very self-explanatory. But as far as the slides are concerned, the slides is what we went through today. And that's pretty much that is going to be asked on your slides. Is that good, guys? Okay.
Are we
So
going to
I'll
have
make-
study sets?
What is that? Yeah, there is a study set. I'm going to share that with you. You just finish it. Give yourselves a break.
Oof.
I will share the study set with you as well. Okay. And you guys will have access to this PowerPoint so you can go back, and it was very content heavy, but I have faith in you guys. I think you guys understood it all. Well, enjoy your rainy and snow day. And we here in Atlanta will go out. You guys have a good Saturday. And I will see you guys in the new year.
Thank you.
Thank you.
Thank you. Bye.
Thank you.